I have 30 minutes to talk about cardiovascular disease and sleep apnea, and there's been a lot of research in this area over the past, say, 10 to 15 years, and I've tried to include that. I'm going to be kind of flying through a bunch of material here, so bear with me. In terms of the purpose of the talk is to describe the types and prevalence of sleep apnea and its meaning in patients who are at risk for or who already have cardiovascular disease. The emphasis of the talk will be recognizing patients with cardiovascular disease who have coexisting sleep apnea, understand the mechanisms by which sleep apnea may contribute to the progression of cardiovascular condition that they have, and to review positive airway pressure treatment in different disease conditions. The main questions in the research, and some of these answers will be provided today, but not all of them, is number one, does sleep apnea initiate the development of cardiovascular disease? Does sleep apnea accelerate heart disease progression? And does treatment of sleep apnea cause fewer cardiovascular events and reduce mortality? Unfortunately, there's a lot of letters in the sleep world, and you've probably seen some of them, but in the talk today, I'm going to be using a lot of these. SDB is sleep disordered breathing. OSA, as you know, is obstructive sleep apnea. CSA is central sleep apnea. CSR is Cheyne-Stokes respiration. AHI, as you may know, is apnea-hypopnea index. CAI, central apnea index. PAP, CPAP, you probably know from reports, and it's positive airway pressure. So in general, there is a high prevalence of sleep disordered breathing in cardiovascular disease patients. It affects 15 to about 30 million adult Americans. And down below here, you look at the prevalence among different cardiovascular conditions, and you see that 60% of stroke patients have some form of sleep disordered breathing, 50% of CHF patients, 45% of hypertensive patients, 30% of coronary artery disease patients, and 80% of drug-resistant hypertensive patients. The evidence in terms of the research that's out there right now, there are epidemiological studies, longitudinal studies, cross-sectional studies, cohort studies, and a few small randomized controlled trials. Some larger randomized controlled trials are being done right now. But in general, the limitations of the research are they're limited because there's a close association between obesity and sleep apnea that obscures the differentiation sometimes. But I think the research has really been trying hard to differentiate the two. There are multiple comorbidities seen with sleep disordered breathing. As I mentioned, a lot of the cardiovascular disease that's out there, metabolic syndrome and diabetes, and also the randomization of sleep apnea patients to treatment or not treatment, but it's kind of difficult to do that if you have very sleepy patients that really need treatment, or if you have commercial drivers, for example, that need treatment in order to be able to continue to work. Topics of interest of this talk, I'm going to go over definitions of the different kinds of apneas, go over diagnosis in terms of how to diagnose a few of the apneas, pathophysiology, and then I'm going to talk on different cardiovascular disease states, hypertension, heart failure, stroke, etc. So by definition, an obstructive sleep apnea is repetitive cessations in ventilation during sleep caused by the collapse of the pharyngeal airway. And you see here, this is the breathing in and out of the nose, breathing in and out of the mouth, the chest rising up and down, the belly rising up and down, the oxygen levels. And what you see here is you're breathing, and then there's no breathing, and you're breathing, and then there's no breathing. But there's still effort down here of the chest and the belly trying to take a breath, but there's no air movement going in and out of the nose or in and out of the mouth, and then you have drops in your oxygen levels. Obstructive hypopnea, similarly, there are repetitive interruptions in the ventilation caused by incomplete collapse of the pharyngeal airway. Very similarly, you see breaths here trailing off, breaths here trailing off, and associated drops in oxygen level. Central sleep apneas, this is a depiction of the central sleep apnea, but this is more Cheyne-Stokes respiration, where you have a crescendo, decrescendo breathing pattern where you start off slowly and then you have much more deep breaths, and then you end slowly with no breathing. And then there's no breathing in, airflow in and out of the nose, no airflow in and out of the mouth, and then the chest and the belly are not rising and falling either, and then associated drops in oxygen level. This is what normal breathing looks like. There's a big difference. This is a pictorial of what is happening in terms of the airflow, normal breathing through the nasal passages and the mouth, going down into the lungs, nice nice airflow going through. This is where the obstruction happens, usually in the posterior pharynx. So by definition, apneas or hypopneas need to be about 10 seconds or more in length and associated by 3 to 4% drops in oxygen levels. In general, hypopneas are the majority of things that we see, although I have to say I think I see a lot of apneas as well. In the literature anyway, it says that the majority of hypopneas. In the sleep heart health study of over 6,000 adults, they showed hypopneas with a 4% or more greater reduction in oxygen saturations with the respiratory event is associated independently with cardiovascular disease. More about on definitions, an apnea-hypopnea index is when you count up the number of apneas or no breathing, count up the number of hypopneas or diminished breathing, and you average that over the course of the night in terms of per hour. That's the apnea-hypopnea index. And if you're greater than 5, associated with 3 to 4% drops in oxygen level with excessive daytime sleepiness, that's the definition of sleep disordered breathing. In general, it occurs in 1 in 5 adults. Mild sleep apnea is an AHI greater than 5 but less than 15, and then more severe, moderate to severe apnea or more severe sleep disordered breathing happens in 1 to 15 adults with apnea-hypopnea indexes greater than 15 per hour. In general, there's a significant progression of sleep apnea over time with age. Turning to central apneas, it's a little less clear as to exactly how much and what the standards should be for central sleep apnea, but central apnea index, there was a study done in Pennsylvania, showed a greater than 2.5 index is not really seen in patients less than 44, but increases significantly over the age of 65. There was another study from the Sleep Heart Health study showing there's about a 9% prevalence in patients 40 to 97 with a central apnea index greater than 1. In general, central apneas are seen more with people who have diabetes, heart failure, LV dysfunction, and stroke. They occur fewer in women than in men who have heart failure. And then there was another study that showed a central apnea index of greater than 15 per hour occurred in 40% of men who had heart failure. Pathophysiology of sleep apnea starts with a small pharyngeal airway, whether that's due to weight or structural, if you're born with a small airway or micronathia. There's airflow resistance and a negative interthoracic pressure that is created, interpharyngeal negative pressure that's created, and via the mechanoreceptors, there's an increase in the number of dilator muscles that are used to keep the airway open, so your airway stays open. However, with sleep, you don't have the mechanoreceptors working very well. You're not able to stimulate your dilator muscles. You don't maintain your patency, and then you have pharyngeal narrowing, intermittent collapse, hypoxia, hypercarbia, which stimulates your ventilatory drive, causes arousal, sleep deprivation, and then there's a vicious cycle happening. Going a little bit more deeper into the pathophysiology of sleep apnea, there is volume loss with longitudinal contraction leading to collapse. There's upper airway dilator muscle control variability. As you already know, I mentioned arousal. There's an increased arousal threshold. There's asynchrony to activate the airway muscles. There is variable surface tension that occurs. There is ventilatory control instability. And then there's also deficient airway anatomy, whether that's micronathia or just narrowing of the airway. More on the pathophysiology now related to the mechanism of disease and increasing cardiovascular risk. There is variability in heart rate and blood pressure. There's sympathetic activation causing heart rate to be increased during wakefulness. There are increases in vasoactive substances like endothelin. There are a variety and numerous inflammatory responses that happen, including increases in pentraxin-3, IL-6, C-reactive protein, nitric oxide, NF-kappa B, TNF-alpha, adhesion molecules, serum amyloid A, and leukocyte activation. There's also a bunch of substances that are produced with oxidative stress. There are intrathoracic changes that happen, and I'll go into the Mueller maneuver in just a minute. There's increased fibrinogen and thrombosis. There is decreased leptin levels and glucose intolerance, and then there is more endothelial dysfunction related to the hypoxemia and systemic inflammation. And this is where we think that the cardiovascular risk is coming from.